Okay, so good morning, everyone. My name's Cajetan. I'm one of the IMT1 trainees in Conquest Hospital in Hastings, and I'm probably currently asleep in bed as I'm on nights while you're watching this. So I've recorded it in advance, and I'm doing this presentation with my consultant neurologist, Dr. Sue Verova. So I'd like to talk today about a patient that we've recently been seeing. He was a ward referral who we went to review. In terms of the chronology, I'll sort of start at the beginning when he first started getting symptoms. So about 6 months ago, he was relatively independent. He'd retired from his work in a factory because of a hernia, but he was still quite active. And he'd come in for a routine hernia repair. He had the operation. After the operation, he developed a hospital-acquired pneumonia. He was in bed for a couple of days, and then he found it quite difficult to mobilize after he got better from his pneumonia. So he spent a couple of months in rehab and didn't improve too much. So he ended up going home with a package of care 3 times a day, downstairs living and using a Zimmer frame to get about just downstairs in his home, whereas before he'd been completely independent, and it was mostly sort of leg weakness. He also had a long-term catheter because he'd gone into retention during that original hernia operation admission. And he hadn't been successfully TWOC'd for that. So in the meantime, he was treated for some vitamin B12, vitamin D deficiency, and as I said, he had physiotherapy, but he hadn't really improved. And he came in February because his muscle weakness in his legs and his arms had progressed, and he was now no longer able to get out of bed and weight bear at all. So he'd come in for investigation of that weakness. So in terms of his past medical history, he had hypertension, retinal detachment previously, so that he actually couldn't see out of his left eye. He had neurofibromatosis, which had contributed to the retinal detachment. As a child, he had pseudochondroplasia type 1, which meant that he had to have an orthopedic operation to lengthen his right tibia, and then it meant that his right ankle was kind of fused. He had some element of CCF, but not very severe. He'd only had 1 admission with an exacerbation, and it was well controlled. And he had had previous surgery twice for brain cysts, again associated with his neurofibromatosis, and they'd been successfully removed, and he hadn't suffered any complications from them. So as I've covered, he had previously been retired. He had previously worked in a factory doing quite a lot of heavy lifting until about 3 years ago, and then retired because of his hernia. And currently he's having that downstairs living with carers. He has a family history of neurofibromatosis as well. So his mother had neurofibromatosis, and pancreatic cancer. His brother had pancreatic cancer. He's just on standard medication for CCF. Duloxetine he takes because he gets some nerve pain in his left leg on and off, and tamsulosin he was taking for his prostate. So on examination, the most obvious thing is that he has these widespread cutaneous neurofibromas all over his skin, quite a lot of cafe au lait spots as well. The other sort of main noticeable thing is that he's got quite a lot of muscle wasting in his shoulders in particular. So his distal arms were pretty spared and had preserved most of their muscle bulk, but his shoulders were just sort of skin and bone. And the power in those shoulders was severely reduced to the point where it was making it difficult for him to do simple things like feeding himself. He could feed himself with his left arm. He was just about able to raise the shoulder up in order to get it to to feed his mouth, but he wasn't able to use his right arm at all for that because he wasn't able to abduct the shoulder far enough. But more distally, his arms were fairly strong, just slightly reduced power, 4 out of 5, and good elbow extension, quite good strength in the hands. A little bit of loss of muscle bulk, particularly in the hands, was noticeable, but not kind of extreme guttering or anything like that. Again, in the legs, it was again more proximal muscle weakness and a little bit of loss of muscle bulk, but nothing dramatic. But yeah, it was noticeable weakness on hip flexion. Knee extension was a little bit stronger, and there was fairly good muscle bulk in the more distal lower limb, and yeah, plantar extension flexion wasn't too bad. It wasn't possible to test on the right because of his pseudochondroplasia operation, and sensation was completely intact everywhere. Cranial nerves were normal, aside from obviously not being able to see because of the previous retinal detachment, and his reflexes were normal to brisk. I say they were a bit more on the brisk side, but they were all intact everywhere throughout upper and lower limbs. So obviously I haven't got all the information we need, but just to try and get you thinking, what kind of diagnosis do you think we should be thinking about for this gentleman? So the options are A, neurofibromatosis neuropathy, B, paraneoplastic syndrome, C, motor neuron disease, D, Guillain-Barré, E, multiple sclerosis. So I'll let you think about that just for a little bit. And try and decide which one or two or three you think most likely. Okay, so just going through them now. Neurofibromatosis neuropathy was the first pathology that we thought might be going on, given the fact he had this extensive neurofibromatosis, had previously had cysts in the brain, and we were just wondering, was it involved more in the nerve roots as well, and was it causing this sort of widespread neuropathy? Was it just sort of a progression of his disease that he was developing more and more and more of these neurofibromas, which were causing nerve impingement and nerve damage? B, paraneoplastic syndrome, that would be, I think, a reasonable thing to suspect as well. Aside from the fact that most paraneoplastic syndromes generally affect the more distal peripheral nerves first, and you have this sort of ascending weakness, whereas this gentleman seemed to have more of a proximal weakness. So the one obviously sort of exception to that might be Lambert-Eaton syndrome. So that's probably something to bear in mind, because that can present with more proximal myopathy. So that's something that we also had kind of on our radar as well. C, motor neuron disease, the mix of kind of peripheral and central symptoms that this gentleman was having could fit with motor neuron disease, so that was something that we were also looking into. Guillain-Barré, generally more acute, more of an obvious trigger, again more ascending, so this is much more unlikely. We weren't really concerned about that. Multiple sclerosis, also the fact that this had been progressive, it wasn't relapsing, remitting, there were no eye symptoms, didn't really fit with multiple sclerosis. So the first three are kind of reasonable ones to consider for this patient. Okay, and just on the subject of neurofibromatosis type 1, which of these features do you think are involved in neurofibromatosis? So, or can be seen in a patient with neurofibromatosis type 1. So we've got A, leash nodules, B, scoliosis, C, learning disabilities, D, cafe au lait spots, or E, all of the above. I'll give you a few seconds just to think about that and think about which answers you would choose. Okay, so the correct answer is E, all of the above. So just a little bit of information on neurofibromatosis. It's a mutation caused by a mutation of chromosome 17, which affects a tumor suppressor gene for neurofibronin, and it's autosomal dominant inheritance, although lots of people are thought to have it by a de novo mutation as well. They say roughly 50-50, but this gentleman had, his mother had neurofibromatosis, so it fits there. And it involves all of the features I mentioned. So leash nodules, which are sort of orangey brown freckles you see in people's irises, benign neurofibromas across the skin, and larger ones which come together are called plexiform neurofibromas. Scoliosis is quite common. Learning disabilities, often very mild learning disabilities, and not everyone has the learning disabilities. There's quite a spectrum. Vision disorders, as well as this gentleman's had, multiple cafe au lait spots, pheochromocytomas can occur as well, and epilepsy can occur if there's more central involvement, if you get more central nervous system neurofibromas as well. But generally, neurofibromatosis type 1 is more of a peripheral nervous system, and neurofibromatosis type 2 is a bit more central. Okay, so here are some images. You've got the picture on the right of the extensive neurofibromas. They're kind of fleshy, soft nodules, not tender, and they increase with age across the skin. And this gentleman had a similar extent of them, I'd say, and all across particularly across his trunk, his back, some on his face as well. You also have, as you can see on the picture on the left, cafe au lait spots. This is in a younger patient. And then looking at the eye, you can see those leash nodules around the iris. Okay, so features of neurofibromatosis type 2. Which ones here do you think fit with neurofibromatosis type 2? So we've got A, ash leaf spots, B, deafness, C, shagreen patches, D, retinal hamartomas, or E, adenoma sebaceum. So which of these would you say fit more with neurofibromatosis type 2? Give you a few seconds to think about it. Okay, so I was a bit cheeky here and I put in 4 features of tuberous sclerosis, which can sometimes be confused with neurofibromatosis when we're thinking about it, but it's quite a different condition. So the 4 features of tuberous sclerosis are A, C, D, and D, and so deafness is the main feature that we see in neurofibromatosis type 2, because it's more of a central nervous system problem where the neurofibromas develop. Okay, so it's caused by a mutation on the NF2 tumor suppressor gene on chromosome 22. So it's very unrelated from neurofibromatosis type 1, and it causes bilateral acoustic neuromas. So these are tumors of the vestibulocochlear nerve, which lead to hearing loss. You also can get other kinds of brain tumor, other neurofibromas, meningiomas, gliomas, or schwannomas, and it usually requires surgery to treat. Here's just an MRI showing those vestibular neuromas, but you can also, with the white arrows, but you can also see with the black arrows that there were some other brain tumors which look like meningiomas. Okay. So just thinking about this patient, given the symptoms that he's had, the history that he's had, what kind of investigations would you like to do? Just have a think about what things you'd like to do, what things you'd like to find out. Okay, so let's go through the investigations we did for him. So he'd already had some neurology outpatient investigations. He had some CT head, CT spine in December, which the CT head showed some evidence of previous surgical intervention. He had some neurosurgery to remove those cysts. Also some moderate diffuse cerebral atrophy and some background microvascular disease, which you'd kind of expect in someone of his age. But there were no obvious masses, nothing very dramatic, or no recent intracranial events either. Okay, and CT spine again showed some bony changes and multi-level spondylotic changes, which you'd expect with someone who's had quite a physical job most of their life. But again, nothing special. CT chest abdo-pelvis didn't show anything suspicious, which was quite reassuring about something like Lambert-Eaton syndrome, let's say, because you'd expect to find some kind of mass, some kind of cancer, although obviously it can precede there being an obvious cancer, but it was still quite reassuring that there wasn't any obvious tumor going on, no obvious pheochromocytoma or anything like that. His MRI spine again showed some foraminal stenosis and some compression of the right C6 nerve root, possibly, but there was no spinal canal or foraminal stenosis, no obvious, big fibromas that could be causing this neuropathy that we thought might be going on. No conus medullaris and the conus medullaris and the chorda equina were normal, and there was no abnormal enhancements. Again, no big lesions anywhere, and the fact that chorda equina and everything was normal again, shows that there's probably doesn't really fit with the fact that we're seeing this weakness in the legs as well. MRI of the brain, again, no abnormal enhancements, so no lesions. Some asymmetrical gliosis in the left cerebellar hemisphere, but that was more to do with his previous neurosurgery. Okay, and we did a paraneoplastic screen as well, looking for any sort of autoantibodies that might be triggering this, and it was all negative. So again, that was reassuring from that perspective. So finally, we did nerve conduction studies, EMG, which showed marked neurogenic changes in both upper and lower limbs, but also what was most interesting from this was that there were prominent fibrillations seen, and fasciculations as well were picked up. And this is something that I hadn't really noticed in my initial examination of the patient, so I went back to look at him again. Okay, so on re-examination, he did have subtle fasciculations in his upper limbs, and the thing about fasciculations, especially early on, is it's very easy to just not notice them if you don't actively make yourself look for them, if you don't actively kind of get the patients to relax, expose the limbs, so you can really see all the muscles and just see if there's any movement going on, and give yourself a good couple of minutes to do that. if you don't do that, as I didn't really do in the first examination, you can miss it. But when I went back to look at him again, with the benefit of having seen the EMG, I was able to see some fasciculations, particularly in the arms. So here's a video of more prominent fasciculations, which I can show you now. Okay, so just to see what they look like typically. See. And if you're not looking for them, if you're not, getting the patient to relax, I mean, this one's quite easy to see, but in more subtle cases, then you won't be able to see them, and they can be often stimulated, as you can see in the stimulated by tapping as well. You can see the brachioradialis there fasciculating quite nicely. So it's just something that's worth always looking for when you get time and then you're examining someone with weakness. Okay, if there's muscle wasting as well. I'll go back now to the presentation. Okay. So let's talk about motor neuron disease, because that's what it's more looking like now with these fasciculations and the mix that we've seen of symptoms. So just to, again, engage your brains a little bit, here's a little MCQ. So which features here do you think fit with motor neuron disease? So A is most commonly diagnosed in age 25 to 35. B, cerebellar signs. C, fasciculations. D, mixed peripheral and central signs, so mixed upper motor neuron, lower motor neuron signs. And E, sensory neuropathy is also common. So just have a think about which ones of those you think are kind of seen in motor neuron disease. Good. So the age is normally a little bit older. So it's oh, sorry, that was YouTube just playing another. There we go. That was YouTube just moving on to another interesting neurology video. So yeah, going through the answers to this features of motor neuron disease. A, it's most common in age 25 to 35. That's not correct. It's normally presents later. B, there are no cerebellar signs, so that's not correct. C, fasciculations is kind of classic with motor neuron disease. D, mixed peripheral and central signs, which are upper motor neuron, lower motor neuron. Yes, that's also typical with motor neuron disease. And E, sensory neuropathy, is common. That's false, because it's a motor neuron disease, so there's no association really with sensory neuropathy. And if you're seeing mixed with sensory neuropathy, you probably need to think about something else. Okay, so yeah, motor neuron disease is a disease of unknown etiology, rarely presents before the age of 40. The vast majority of patients are older, and you see all the signs that I've discussed there: fasciculations, absence of sensory signs, mixed lower motor neuron, upper motor neuron signs, wasting of the small hand muscles, which our patient did have a little bit of, and tibialis anterior. Sparing of the external ocular muscles. Obviously, those ones are the ones that aren't affected. That's why Stephen Hawking was able to continue communicating with his eyes. No cerebellar signs. You don't see them, and you can see sphincter dysfunction, but it's a late feature, and it's a clinical diagnosis. But nerve conduction studies are quite useful to show normal motor conduction. And they'll help exclude a neuropathy, which was the case with our patient. And they also are useful for showing fasciculations before they're clinically obvious, which again was the case for our patient. So there are different types of MND. There's ALS, which is a mix of lower motor neuron signs in the arms and upper motor neuron signs in the legs. Primary lateral sclerosis, upper motor neuron signs only, progressive muscular atrophy, lower motor neuron signs only, and it affects distal muscles before proximal, and progressive bulbar palsy, which is the worst one because it affects the tongue, muscles of chewing, swallowing, facial muscles, and so it leads to death a lot sooner because of aspiration and any difficulties with feeding. So another MCQ for MND management. So which, if any, of these medications are used in managing MND? Rivastigmine, rifampicin, riluzole, rilpivirine, or IVIG? Have a think about that. Okay, so the correct answer is riluzole, but it's not great. So riluzole prevents stimulation of glutamate receptors, used mainly in ALS, and it can prolong life by about 3 months. So some patients do start on riluzole, but not by no means all patients will start on riluzole. So the main thing with motor neuron disease, it's progressive. There's nothing we can do to treat it. It's important when you diagnose a patient to really prepare them for the diagnosis. You give them a few warning shots if possible. You tell them that they've got kind of progressive muscle weakness, and then don't use the MND word immediately. Maybe come back the next day and discuss that with them. Because some people are quite aware of motor neuron disease kind of culturally and think, oh gosh, that's a death sentence. And in some ways it is a death sentence, but you don't want people to then go away, especially when they're healthy, and do something silly like kill themselves. So you need to really support them in that diagnosis and support them with all of the information they need about it, so they really understand it, and information about what kind of support they can get. And the best resource for that is the Motor Neuron Disease Association, which I put a link into there, which they have teams up and down the country with special nurse coordinators who coordinate with neurologists in London, looking at different trials, but also more importantly, I think the really practical aspects they help with of getting the right kind of equipment in place at home, the right kind of carers coming in. They do things like voice capture, so that if people, before they lose their voice, they can have this. There's a computer program that will store their voice, so they can continue communicating with their own voice. So there are lots and lots of different things that can be done to make their lives more comfortable and able to prepare them for future progression. Okay, so as I said, there's only really riluzole in terms of medical management, and it's not great. At some point, many of them will need respiratory care. So as their respiratory muscles weaken, they can have BiPAP, and there's some studies showing that it can increase survival by quite a few months. But they need to be very comfortable with using it, particularly if they don't have anyone around at night with them, because of taking the mask on and off if they panic or if they vomit or something like that happens. They need to be very comfortable with it, so they need to have a lot of time and training with it. And prognosis is very variable. It can be many years, or it can be a very short amount of time. On average, about 50% of patients die within 3 years of diagnosis. But yeah, it really does vary, and the best way of kind of prognosticating is to see, how fast has it progressed up until the point of diagnosis, and then how fast does it progress in the following months, and that gives you kind of an idea of the rate at which they're going to change. Okay, that's the end of my presentation. I believe Dr. Suvarova will be taking questions and giving tips on how to approach patients with weakness. But thank you very much for listening.